Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. As many of you know, the NSCHBC is a proactive organization with over 300 members, including legacy members, that share their wealth of knowledge and expertise with each other and with all of us. Whether it be in the legal field, the accounting field, the revenue cycle management field, business management, value-based care, and more, we have every kind of consultant that focuses on the healthcare industry that you could want. So for today's episode, I'm happy to welcome back NSCHBC member and Education Committee Chair, Healthcare Attorney Amanda Waesch of Brennan Manna Diamond LLC. Welcome back to the podcast, Amanda.
Thank you so much, Terry. I'm so happy to be here.
I am happy you're here too, and it's February already, so boy, 2026 is starting off quickly.
I know. I couldn't believe it when I looked at the calendar.
I know, crazy. So today we're going to have an interesting topic. I think we visited on the podcast in 2023, believe it or not. And so for most of our listeners who haven't heard it for a couple years or aren't actively in it or are struggling with it, I'd like to talk about the No Surprises Act and what we're dealing with for 2026. And actually, is it No Surprise Act or No Surprises Plural Act?
That is a good question.
Okay, because every time I look it up either way, both come up. So I'm not sure.
They both come up, right? So a lot of people will just refer to it as the NSA.
Yeah.
I call it the No Surprises Act.
Me too.
Yeah.
Whenever I hear NSA, I always think it's, NASA, the space program.
Oh, yeah. I know. I guess I never thought about that.
So I always have to say, what are we talking about here? And actually, I know you have a couple stories that go on with this topic, so it probably could be the space program and with some of the things that we're dealing with. But just to lay the land for our listeners, so the No Surprises or Surprise Act in 2026 and what we've been dealing with for the last couple of years, it protects patients from surprise bills for emergency care and certain, not all, out-of-network services. And it has a lot of discretions and developments in some of that enforcement discretion for qualified payment amounts, basically what, the doctor actually is going to get paid. They focus, I know that some of the regulatory focus is going to change or at least be updated for good faith estimates, explain to the patient what they need, what they will possibly pay out of pocket. And then the good old independent dispute resolution or IDR. So when we're looking at some of this 2026, and I also saw a new House resolution bill too, 4710, but I've seen that kind of stall. What are you seeing? Let's start with the first thing. I noticed that a lot of practices are a little frustrated only because the enforcement, things and what they're getting paid or even just getting somebody to talk to them at the payer level has been tough. What do you see there?
Yes. So I see frustration from hospitals and health systems, and then also with the billing companies that I work with. Especially the billing companies, because they're trying to help their clients, right, which are the healthcare providers. And so they are filing hundreds of IDR requests, right?
Oh my gosh, really? Wow.
Well, if you are an emergency room, or we have some specialty hospitals where the surgeries are out of network, and then the insurance companies, in some instances, are paying, pennies on the dollar, and they're not able to get to a resolution. It's just very cyclical for them, and they feel extremely frustrated. And so we have, them trying to, they're appealing, they're filing the IDRs, the independent dispute resolution. They're not able to come to acceptable agreements. It's very subjective too, right? What is the rate that they want, and what is the rate that the insurance company is willing to pay? And and then you've got patients that are stuck in the middle. And I feel like, in at least the instances that I hear about, that they're still very frustrated by the process. And again, when it gets to me, right, they feel like they're out of options.
Right. And this is where this is where the frustration I'm seeing, not just from patients, but providers as well, is that, and you hit it on the head as far as patients getting caught in the middle. Sometimes the billing companies are getting so frustrated that they just go ahead and send a statement to the patient. And
Yes.
the patients are screaming, saying, no, 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 I have insurance or had insurance or whatever at that time. And, personal story, a couple years ago, had a blood pressure episode, so we had to go to the hospital overnight. And the ambulance, and the ambulance issues,
Mm-hmm.
they asked me for my insurance and a copy. And I actually, why they were in my house, and I didn't even want to go in the ambulance. I'm like, just Tom, take me over. And they're like, actually, if you go in an ambulance, you'll get seen. If you go in a car, you're going to wait in the ER for like 3 hours.
Yes.
So I'm like, all right, let's go. so, so anyway, they, took my information. I even saw them take a picture of anything. And then like a year, I get a statement for, $2,200. And I'm like, what are you talking about? Call my insurance, the whole thing. Oh, we never got anything. We never even, and I never saw an EOB. So I never saw anything. And so, I had to quote the NSA. I had to let them know, you already have this. Here it is again. Well, then my insurance changed. So then, and I didn't hear from them for another year. And I kept hearing from them once a year. And I haven't
Mm-hmm.
heard it. Yeah. So, and I've really had to kind of threaten not just the, federal rules, but here in California where I'm at, we've got a pretty strict No Surprises Act rule as well, where you just can't surprise us with something, especially if you had an opportunity to bill the insurance. And I think this is where, and this is my question to you, are you running into areas where it's not only that the services or the provider was out of network and now they're trying to get paid at least an in-network amount, but that something may have not have been billed, and
Yeah.
now
Oh,
there's
yes.
expired now where they can't even go after it.
Yes. And I actually had that happen to me personally
Yeah.
with a health system. I went in for a procedure, and whoever had put in my insurance information had transposed the numbers. And so the insurance kept rejecting it because two numbers were switched. And so I never got an EOB because the insurance had rejected it, right?
Right.
And then
Yep.
I get this bill and it says insurance did not cover. And I said, insurance should definitely cover this. This was it was a surgery related to my pregnancy. And so I knew that insurance would cover it. And it took me many, many months to figure out that someone had transposed the numbers. Well, at that point in time, timely filing had expired, and they're still coming after me for the bill when it was entirely not my fault. And so the
Right.
insurance company was digging their heels in, saying, look, hospital, this was on you. Um, I think that was a little bit unfair because it wasn't an intentional error. But then the hospital said, well, your insurance denied it. We're coming after you. And I said, well, this was your mistake. And ultimately, at the time, this was a couple years ago. Well, I'm dating more than a couple years ago. So the No
Yeah.
Surprises Act was not in effect. But I said, look, I know you're accredited by the Joint Commission. So I'm going to call the Joint Commission, and I'll call the Department of Health, and we will resolve it. We'll resolve it this way. But yeah, so it may not be surprise billing, right? It may not be out of network billing. It may be a billing error
Or
where
they
it is
didn't file it at all. Yeah, exactly.
exactly. I'll
Yeah.
give you another example that I just had 2 weeks ago. We represent an estate, and a hospital system filed a claim against the estate for an unpaid bill for a surgery. And this was a traditional Medicare patient with a secondary.
Wow.
And yes, and Medicare paid it. The secondary picked up the 20% copay. And this is a large health system, balance billed the patient, well, the estate, $48,000. So
Oh
it
my
took total,
gosh.
yes. And so again, that is That is a surprise, right?
Well,
Not
that's
the
why
surprise.
when I went to the ER overnight, I did get an EOB for all the charges that were submitted, and then they submitted it with the wrong diagnosis, and it was $101,000 for less than 24 hours, Amanda. And I was like, whoa. So I was
It's
really
insane.
hoping that somebody submitted the claim. I never heard anything back. Never heard a word. And they didn't, my insurance company said, no, we're not paying all that. So I think they only paid like $800.
Right. Yeah. So we get, so every one of these bills is a surprise, right? But we have to
It's crazy.
analyze, does it fall under the No Surprises Act?
Right. And
Or
that's
is
that's
it
a big
due to
thing.
some, right? Or is it balanced billing? What is the issue,
And
right?
I think that's what you kind of have to look at. This seems to be balanced billing. It's not, but then again, it's not. When you look at the letter of the regulation, it's more about out of network, in network, and it doesn't really allow for mistakes by the entity where you had services.
That's right.
So there's a lot of confusion of when you can file. Is this really a No Surprise Act issue? Is it on the provider? Because now, since they've made all those mistakes, like you said, transposed numbers, like I said, they never even submitted it. Now can they
Mhm.
go after the patient? I mean, there's a lot of issues there, and you and I are both healthcare professionals that get it and know where to deal with this, but a lot of people don't.
Exactly. Exactly. And so the No Surprises Act, while I get it, I understand why they passed this federal law to protect consumers. It only applies in very limited circumstances. And you said that in your opening um, statement, to use a legal term. It's only specific instances. It's
Only in
where
certain things,
we're,
yeah.
yeah, where we're seeking emergent services at an out of network facility, right? We don't have any choice, or where we think we're going to an in network facility, but then we have providers on the back end that we don't even choose that may be out of network. So it's very, very limited um, when the No Surprises Act will apply, which I think is deceptively, it could be a little deceptive for providers because a lot of them think, oh, it doesn't apply to me.
Well, and in the providers that I've talked to, they said, I'm tired of having to even deal with this IDR and trying to get, paid at least what the in-network. There was a reason I opted out of this plan because
Right.
I wanted to be able to, get an out-of-network fee since I am an ER doctor or, gosh, anesthesiologists. They really kind of get, I hate to use the word screwed on this, but they do. And
They do.
they
Yeah.
basically are like, oh my gosh, this is crazy. Well, then they try to, so I had one group, a big anesthesiologist group, they were trying to get into this one UHC, and they couldn't. They said, no, we're closed for new providers. So they're stuck. They couldn't even get on that, to be a participating provider. They couldn't even contract with them. So so they're like, okay, so now what do we do? We're getting the lowest fee. We're not even getting the, geographic location qualified payment amount calculation. We're actually getting just the very lowest Medicaid rate, which I noticed that a lot of these resolutions, if you will, end up doing. And, and I also think about, are patients now seeing that they can kind of manipulate the system a little bit by getting really bad insurance and paying less for it because they're only going to have to pay out of net or the network cost anyway?
Ooh, that's a good question. I have not seen that, but could that be where we're headed? Because I think that consumers, I really didn't have a whole lot of, I saw a lot of IDRs,
Yeah,
right? And that is, I'm out of network and I need to negotiate with this payer. And, so you saw that early on.
right.
Now I'm seeing more consumer complaints.
Yeah,
I think consumers are getting very educated, and these are legitimate complaints where I think we have issues with the No Surprises Act. So wading through, is this an NSA issue? I would say yes, we're starting to see those. And the patients are getting savvy. I think they're sharing on social media. If you want to get out of this bill, here's
here's
what
what
you
you
can
do. Yeah,
file.
exactly. And I've seen
Is the
now,
next
yeah.
step, do we go to, this is the plan we go to? That's a good question.
Yeah, I'm just starting to see that question come up with a lot of my clients. Are like, patients are now, because health insurance is really expensive this year. I know mine went up from 705 premium to 924 a month just for me,
Oh
just
my
for me. And I'm a healthy
God.
adult.
Yeah.
But it was crazy. And so, people are saying, well, I'm going to just get the highest, deductible of 15,000, the highest copay, so I can get is the lowest premium possible. But then I know when I go get my services, I only am going to have to pay the in-network amount. And I'm like, well, not really. I mean, but I'm seeing them argue that fact. And because not everyone
Mm,
understands that
hmm.
it's, there are just certain out-of-network issues there and certain emergency cares, I'm seeing that a lot of people are thinking that, they can kind of get around the system. And it concerns me a bit, especially now because we have some uninsured people because they couldn't afford their premiums. And the NSA, as you know, mandates that providers give uninsured or self-paying patients those good faith estimates, and they have to be within $400. But you don't
Right.
always know what if there's a complication or if there's a problem. And this is where the gray area is that you'd know better than me, I think, from a legal perspective. It was when it first came out where you also had to give, if you're the primary provider, so let's say you're the surgeon, you had to give a good faith estimate for any uninsured or cash patient. And a lot of patients are like, well, I have a $15,000 deductible, so I'm a cash patient. I'm like, oh, geez. So yeah, I'm like, okay, great. Now we're into weird territory. But then they're like, but I remember the first draft of this said you also had to do it for any providers that are
Yes.
part of that patient's, circle of what they'll need done. So you're the surgeon, so you have to deal with anesthesia, the facility, the PT, all of that. Is that still there?
That is still there. That is still a
Oh,
requirement. And I'll tell you, so I got 2 complaints in the last month for a lab client that I represent. And the lab is in network with most providers or with most payers, but there are a couple that they're out of network with. And the lab primarily services physician clinics. And so when you said the No Surprises Act applies to some, not all, with the good faith estimate, we are worried about in-network participating facilities. So that would be hospitals, ambulatory surgery centers, not physician clinics. So my lab is thinking, I don't really need to worry about No Surprises Act because I'm getting my specimens from physician clinics. Well, what they didn't realize is some physicians were using ambulatory surgery centers. And so they were getting samples from ambulatory surgery centers, and there is one plan that they are out of network with, and they balance billed the patient. The patient got a surprise bill. And so of course, the patient complained about the lab, and they got 2 patient complaints. So again, these patients are getting very savvy. And we went back to the physician, and the physician had no idea, right? The physician had no idea that he or she had this obligation to provide the good faith estimate. The facility is really not interested in doing it because it's just a huge burden to them. But they've got, this was the lab provider. I don't know about the anesthesiologist. I'm sure that there are some little plans that the anesthesia group may not be in network with. So it
well, and I think what's
there's,
happening too,
yeah,
you mentioned labs. I think sometimes patients look at the amount that they're being surprise billed and like, all right, I'll just pay that because I don't want to deal with it. And instead
yes,
of, and doctors too, they're just like, what, I'll just write it off because I don't want to, it's more expensive to go through the process. And
yeah. So
that's a problem.
that's a good observation. So what's interesting about this case is the patient actually had out of network benefits. So
Oh,
the lab, right, and paid some out of network benefits and adjudicated the claim. And after I picked myself up off the floor, I looked at the EOB, or I looked at the bill, and the lab knew that they probably couldn't completely balance bill under the No Surprises Act, so they adjusted the claim to the Medicare allowable
wow.
and said we're going to, thinking that they were complying with the No Surprises Act, which we know that that's not compliant, right? You
not
just can't adjust
compliant,
it.
right.
It's what would the patient's responsibility be if the claim were in network?
Right.
So they attempted in good faith to kind of do the right thing, but it wasn't technically correct. So then my lab says, well, how do I know what the patient responsibility is if I were in network? They never gave me that information. I looked at the remit and the EOB, and none of that's on there. So that's the other issue is I think I know I need to comply, but how do I comply?
Well, and the other thing I'm seeing too, and this is from my ER groups, is they're like, okay, so what you're telling me, and I'm like, oh my gosh, just so you know, I'm just the messenger. They're like, so what you're telling me is that a patient who's coming in through the ER in distress, I mean, emergent, where we're going to have to just think of a heart attack or something, we're going to have to say, oh wait, can you sign this to make sure that you gave us permission to work on you? I'm like, yes. And they're like, you're kidding. I said, no. I go, otherwise you're going to deal with this whole No Surprise Act thing. You got to make sure that somebody's checked their insurance. I go, there's a lot to be done before you can just say the patient, is in emergent state or having an episode or possibly dying. I said, it's awful. It's really,
Right.
and it's on both sides. I said, because then of course the patient is sitting there going, but wait, don't work on me if I'm going to have a $10,000 or $100,000 bill after. And it's kind of I don't know. It seems like a lot of spinning wheels process.
Right. Right. And on what is troubling on the physician side, and I hear this a lot, is I went to my physician and they sent my labs to an out-of-network lab. And I had no idea. And the No Surprises Act does not apply to that scenario.
Can you tell why? Can you tell our listeners
Yes,
why?
because the physician office is not a facility under the definition of No Surprises Act. So it only applies. So that the portion that we're talking about right now applies to hospitals, long-term acute care, ambulatory surgery centers, facilities, not physician clinics. Now, yeah. So if a physician were to send your specimen to an out-of-network lab, they would not have to provide you with notice and get your consent. Now, so that's that's a little. So that's why my lab client really didn't think anything of it, because my lab client's thinking I service physician clinics and I'm largely in network with everyone. Now, physician clinics do, if they are servicing cash only patients or out of network patients, not referring them to an out of network provider, but if the physician is out of network or the physician is cash only, then the physician needs to present the individual with a good faith estimate. So provide them with notice that they have the right to a good faith estimate, and provide them the good faith estimate within that $400 range that you talked about. So, and a lot of my physicians are saying, well, I don't do that. And I said, I know, but you should, and you should start. So I think we're going to start to see more enforcement and consumer knowledge there as well.
Well, and let me just clarify for our listeners. So you're talking about, labs where they take a specimen in the office, they send it out for the results, and it's a possible, lab that's non-contracted or out of network. This is not the same as being referred out to another provider, referred out for physical therapy, referred out for a specialty thing. That's totally different, correct? Because they didn't do anything in the office.
Correct. So if the physician refers to a specialist or a PT, in your example, the consumer needs to do their due diligence to see if that person's out of network or not, right? But this is, for the lab, that individual has no control over the specimen.
Because they actually did the procedure or took the specimen in the office, and now they're just trying to get the result. Well, and this brings up actually another wrinkle. I'm sure our listeners are like, this isn't a fun podcast today. We're like, we know. We're just trying to be informative. So let's say that, I'm trying to think where I was going with that. So let's say that you have patients that are being referred to, let's say they're in their primary care office and they're being referred to a, gastroenterologist for a colonoscopy. And it's up to them, the consumer, like you said, to find out if they're in network. Well, part of the No Surprises Act, and I think it was like on page, 312 or something, it said that the payers, they have a responsibility to make sure that they have updated in-network provider lists every 30 days or so. And
Yeah.
they're not doing that. And I'm not seeing, Amanda, any policing of that.
Yeah. So that's the other frustrating thing, right? I verify, I think they're in network, and then it turns out that they're not, because that information is fluid. It can change. Yeah. So then they would need to file a complaint, that they relied on the fact that the payer said it was in network. And when they ultimately, when the claim was submitted, turns out we're not in network. So that would be another scenario where the consumer needs to file a complaint. But yeah, I don't see a whole lot of policing of that, frankly.
Me either. It reminds me of when a patient comes in and gives their insurance card saying I'm covered, and they knew they weren't, or they knew it expired, but it didn't catch up yet when it was verified. And so now the provider thinks they have coverage, comes back saying they were not covered, and now you can't even, the patient's gone or whatever. And or you try to bill them, and it seems like kind of a vicious cycle here. So kind of to wrap this up, just a two-part of this. So we've talked about, if you're patients, you do have a responsibility to know what you're covered in network, who your covered in network providers are, making sure you have we don't get a paper book anymore, but make sure you have the website to check, and check often, because it may not be as updated as you think. It's supposed to be updated every 30 days, but we know better. And then also it really is important that, again, patients say, are you sending things out if I have this to an in-network? Are they part of my insurance, so that you're not stuck? But for the providers that are listening, and our administrators that are listening to this podcast, what advice can you give them about just being aware that they need to follow these rules? And just, in saying that, does state take precedence of what your state says over what the federal government says? That's a big one.
Oh, okay. So I'll answer that question first. So the federal law applies like a blanket over the entire United States, right? But if state law is more specific, then we're going to first comply with the federal law, and then also comply with the more specific state law. So you mentioned you're in California. There are specific state laws around surprise billing and balance billing. So the providers are going to have to comply first with federal law, and then also, if they're located in California, with state law that's going to be more specific.
Okay.
HIPAA is a great analogy, right? Everyone has to comply with HIPAA, but you could have state privacy laws that are more specific. They require more specific, faster turnaround times on giving medical records, giving access to medical records, or reporting the test results through the portal. So we can have more state-specific laws that complement. They cannot be contradictory, but are stricter than the federal laws.
Okay, good. Yeah, that's what I was wondering there. Now, do you think that providers need to really be a part of this process, or should they leave it up to their billing companies, their management companies, their administrators? Because I know the doctors just want a doctor.
Yeah, that's a great question. I get it. The doctor should just doctor, right? So, but they should surround themselves with knowledgeable business complements. And a lot of my physicians have tremendous business acumen, but then they make their living seeing patients and treating patients. And so I think that they should, and I think it's reasonable for them to rely upon an individual, whether that's an in-house manager or officer or outside consultant, to help them understand what their obligations are with the No Surprises Act. And then, of course, any complementary state laws. They need to understand, and this is answering, your previous question. One, what type of provider are they? Are they a physician clinic? Are they also providing services in a facility? So what aspects of the No Surprises Act will apply to them? Are they out of network with some payers? Are they providing cash-only services? So understanding what type of provider they are and what type of services they provide, that's going to then dictate what policies they need to implement in their practice to ensure compliance and avoid a complaint.
That's great information. So everyone, in essence, 2026, involves solidifying the NSA impact, resolving implementation challenges, and potentially enhancing its enforcement and transparency through ongoing regulatory action, new legislation. Keep an eye on House Resolution 4710. That's supposed to be taken up hopefully after we don't close down the government again. But we just want to make sure that you have all that information. And we would like to thank Amanda for being our guest today on the podcast.
Oh, thanks, Terry. It was fun.
That's good. It's always great to have you. To find and contact Amanda, you can go to the NSCHBC website at nschbc.org. Click on Find a Consultant, type in her first name, Amanda, and her information will appear. Also, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare Regulatory Update webinar. Please go to nschbc.org and click on the tab Upcoming Education. You don't want to miss any of those. That's it for us today, everyone. Make it a great day, a great rest of your month, and thank you for listening to the award-winning NSCHBC Edge podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.